Hello, everyone, and welcome to this webinar today. I'm Francis Seeley from Global Net 21 and a local group as well called Enfield Climate Action Forum and Enfield Voices. And today we're going to look at some of the issues around health and social care, because there are, a lot of comments about how it's top heavy and that we need to reform it. And there's some wonderful innovations going on around the country about how we can do it differently. And I'm really pleased we've got Ruth Donaldson with us today, and she's the Director of Commissioning in the CCG, the Clinical Commissioning Group. And it's great that she's here, and she's been thinking about it. So she's going to talk to us today about her own ideas. She's not representing the CCG, but she has thought a great deal about it. And it's great that people in her position are doing that, because this is an important topic. So welcome, Ruth, and I'm really pleased you've joined us. Maybe you could start briefly, very briefly, by telling us a little bit about yourself and the position you hold.
Sure. So yes, I'm Ruth Donaldson. I'm the Director of Communities, which is a directorate set up to look at specifically local communities and health inequalities and how we tackle those in North Central London. So kind of a bit about my role, and then I'll say a bit about me as well, because I think, it's very important everyone brings their whole self to work. So the team, the communities team, looks at health inequalities in lots of different ways. So firstly, we have a dedicated fund, and I think that's probably what I'll kind of talk a bit about in terms of how this theory relates into our spending. So we have an Inequalities Fund of just under 9 million, and we use that fund to look at the kind of wider causes of health inequalities, so look at social determinants of health. And we fund sometimes quite small projects based in local communities and aim to really make sure that any interventions are led by and co-produced by local people and bring lived experience rather than just commissioned, if you like, by people in the statutory sector. So I'd be really keen to talk about that in a bit more detail. Homeless health and asylum seeker services, and again, very keen to bring the lived experience to that. We have ex-homeless people in our MDTs, and also our team tries to think about how we influence the wider decision making of the organisation. So how we think about how we spend our money in North Central London, and how we might want to change that over time to really have a really targeted approach on our most deprived and our residents with the highest needs.
I mean, it's really interesting that you're doing that, and you're involved with civil society groups, and you're working from the bottom up, and that's one of the, through collaborative networks, that's one of the innovative ways that people are beginning to work. And maybe we can discuss what you said around some of Hilary Cottam's ideas. And one of the things she said is that since the war, we've been dominated by the Beveridge approach to health and social care, which tends to be top down. And it seems to be impersonal, where relationships between those being helped and those helping are written out because that's not allowed. Is that something we need to change?
Definitely, and I think it is already being changed. So I know there's kind of national examples around. I was at a really interesting seminar this week around women in homelessness, and how if we work more with women in homelessness, they can be advocates for that. I think with anything, if you invest in people, it will pay dividends, because they are the experts. They know better than anybody else about what is affecting their life. So just to give a kind of local example on that as well, North Middlesex Hospital runs something called a parenting network. And this was already set up before we had the Inequalities Fund, but we now fund it through the Inequalities Fund as well to try and kind of maximise its potential. And what this looked at was a number of parents attending North Middlesex A&E, where there was a range of kind of health issues, but the underlying issue that was being picked up was feelings of anxiety and helplessness by these parents. And what this network, this parenting network, tries to do is bring together the kind of state and the kind of medical services, so that it's led by a fantastic paediatric consultant at North Mid. But it also brings into the picture local voluntary sector groups, health visitors, to try and work together, not with the state kind of saying, this is your problem and this is how we think you should fund it or resolve it, but to kind of listen to local parents in terms of what are the underlying reasons why they're going to A&E, and how can we all work together on solutions that would address that. So definitely all the stuff around kind of the importance of relationships and building those relationships rather than a very transactional approach is definitely where we want to get to. But I guess the kind of next step for a lot of what we're doing is obviously 9 million is fantastic. But as a sector, I think we spend about 250 million. That's North Central London. So it's for me, it's how do we take all the innovative projects that are going on and make that part of something much bigger? Because I guess the issue we have is that I think involving people in decisions is fantastic, but how is that then linked to funding? So so I was at an Enfield school yesterday, Eldon School, who were very welcoming. And I was meeting with a community group there, Edmonton Community Partnership, and Health Watch, and New Local, actually. I don't know whether you've heard of New Local, but they're fantastic. I'll talk about those in a second. And we were really talking about how do we use some of our inequalities funding to build a forum around Edmonton that is more representative of local views. So we have fantastic voluntary and community sector organisations in Enfield, but there's some pockets, particularly those with the worst health outcomes. The Somali population, Turkish Kurdish populations often have worse health outcomes than white British. The Eastern European GRT communities. How do we make sure they are at the table as much as all the other groups? And in talking through this with the community groups yesterday, we were trying to get a balance, because on one hand, people were saying this is a fantastic idea. We can definitely reach out and make sure our group is more representative, and also make sure we're linking in with the local authority, because Enfield Local Authority are already doing a lot in this space. But they were also quite worried, because they were saying, okay, if we get everybody together, that we can do that and we can talk to them about, what are their concerns, what's going on in their life. But if at the end of that process, we just say, well, thank you for that, we found that really interesting, it can be counterproductive. We need to do something with that.
Well, you need a model, don't you? I mean, and that's where the Cottam model comes in, and I'm sure there are others. I mean, and you mentioned quite rightly that there's a money issue, there's a funding issue. And I mean, Hilary Cottam was saying in her book that, for example, one person that she dealt with, that she called Ella, had something like 73 services and 24 different people servicing them and 12 people visiting them. And that cost for that family £250,000 a year. And so, the money issue is not about what we put into it, it's what we save, isn't it, by doing things differently.
Yes, definitely. I think the opportunity is there. And it's also, I mean, that was, again, part of this conversation we had yesterday. There were different views around, well, we don't want to raise expectations in terms of what we might do, but equally people were really keen to show the art of the possible, because actually I have my own views on what is possible, but it's really important that is representative. I'm very conscious of my background and what I bring to work, but actually listening to views that were more specific to Edmonton yesterday, and I only live a couple of miles away in Palmer's Green, they were quite different, and they had, that they really wanted to make sure that voice was heard over just even a kind of Enfield voice. So it's how do you enable that, and then how do you change those decision-making processes at a really senior level in the ICS to say, if if the residents of Edmonton or a specific neighbourhood, even if you're going below Edmonton, say, actually, this is what's making a difference in their lives, how do we then make sure that the funding and the mechanisms enable them to actually spend money differently? So the analogy we often use, which was coined by a colleague of mine, Mdad Hack, is feels a bit like when we're spending public money. You know, we've got the menu, but we're not really sharing that with local residents. So we're kind of choosing for them, and all of this is really about how do we make sure everybody is involved in those choices.
Well, the welfare relational model is one where the person chooses with the worker, isn't it? I mean, Hilary Cottam says that in the present system, a social worker spends only 14% of his or her time with a person and 76% on admin. And in the model she's developed, she's found that you get a worker in who spends 80% of their time with a person, and the person that is, you know, she works with actually chooses the worker that's appropriate for them, and then is given a portion of the budget to spend themselves. So it's having a model like that, a similar model like that, you need to develop if you're going to move from collaboration to action, isn't it?
Yes, exactly. And it's having, yes, it's being brave enough to be able to move that money around in that way. And in fact, so one of the projects they have in Haringey, and Dunfield, actually, it's a joint project, is targeting people that they've coined have severe and multiple disadvantage. So for a variety of reasons, and they're kind of identified as being in that cohort. And when we were having discussions about, you know, the kind of differences in how much you use services depending on deprivation. So the example we often use is that if you live in one of our most deprived areas, you're over 3 times as likely to have an emergency admission to hospital as if you want to live in one of our least deprived areas, and then you will stay there for longer as well. So one way of looking at that is saying we must target that, because obviously that's costing us a lot of money, and I'm sure if you looked at local authority spend, you'd see a similar pattern. But really, if you take what Hilary Cottam is saying and then apply, you know, apply it to the nth degree, what the solution to that could be is looking at that total pot that we spend on that cohort and saying, actually, if we converted that into a personal budget, or an element of it into a personal budget, as you were saying, for social workers, I'm sure that would look very different in terms of how they thought the best spend of that resource would be. So yes, as much of this is on setting up those community models as it is changing our kind of financial flows as an organisation and enabling that to happen.
But there are sort of 3 things in that model, isn't there? One is collaboration. The other is the process, the model that you create. And the third is the outcome. And in the outcome, I mean, the Hilary Cottam model, and she's got some local authorities to work with her. In the case of Ella, in the old model, nothing had changed. You know, people were just ticking boxes. It was a containment model. But in the model she had, Ella went into further education, her children went back to school. There were really, you know, positive outcomes. And that's important as well. We can't just keep having this containment model, can we?
No, and I think that outcome bit and how we measure the outcomes is also a really important part of this. So when we were kind of talking to Edmonton Community Partnership and Wellbeing Connect about how you might then measure that's where it's often quite difficult, because obviously we have in the past been quite target driven in terms of thinking about you know, reduction of people going to hospital or time it takes for you to be seen in A&E, which I think is very important. But really, if you want to make that kind of change, you need to be measuring different things, but also sometimes measuring them on a different time scale as well. I mean, all the evidence suggests in investing in children and children's services has a massive kind of return on investment, but the time frame is quite long, and it's how much appetite do people have to do that within particularly at the moment when there's some constraints around that. But the bit that I think is interesting is how can you look at it differently? So we're working with Middlesex University on how you might measure the success or otherwise of the Inequalities Fund, and having this dedicated pot for health inequalities. And although we are looking at kind of things around how often people are going to hospital and how ill they're being, if you only look at that medical bit of it, you only really get into the very end bit, which is a bit late by then. So we're trying to evaluate, as a result of this funding, do people feel that they have more agency in their life? Do they feel they are treated with dignity, respect? Are they listened to? And I think that links back to that kind of relationships element in what Hilary Cottam is saying, because unless you are building up a relationship with people, you're less likely to feel listened to, or that you're treated with respect. And then as part of that, do they feel like they avoided crisis, whatever crisis means? And I think that means different things to different people. But also, how quickly did they feel they recovered from that? Because there's loads of evidence around how even kind of, limited social contact, social connections really increases somebody's recovery time. So those are the kind of things we're trying to look at, but I'm not sure how much the directors of finance are really going to listen to it.
Well, we'll try and make sure he does. Well, I don't know, because maybe we shouldn't. But I mean, the other interesting thing you said, you talked about the parents network.
Yes.
And that fits in with what Hilary Cottam talks about when she talks about developing circles.
Yes.
And she talks about it especially in terms of social isolation, where people are isolated, particularly older people, and they actually want connectivity. But she combines connectivity with events, of getting people to go to events and creating a mutual aid sort of society within it. And it seems that that's what you were trying to do. And that's what, it's really encouraging, that although you don't call it circles, you're developing a circle of your own.
Yes, definitely. And again, there's loads of evidence around that. And I liked something Professor Donna Hall said recently, who's doing fantastic things in Wigan that we're trying to emulate, which is in all this setting up of the new integrated care systems, instead of talking about what committees we've got, why are we not just talking about the basics of things like income and social connections? Because actually that's often at the base of people's lives, and at their ability, that's what affects their ability to live a healthy life. And it is that kind of trying to make the focus on health and well-being in that underlying state, rather than, what do we do when someone's in hospital with diabetes, which is equally as important, but you just need to focus all through the pathway, rather than on that end bit.
And I mean, I mentioned, social isolation problem that elderly people have, and you mentioned, the problems in Edmonton, the inequalities that exist there. And I published a heat map that Age UK did a little while ago on where the incidence of loneliness was in the London Borough of Enfield. And of course, it's all on the east, and it's largely in Edmonton. Doing something there is going to be really important, isn't it? Not now because of COVID, but also because of climate change. It's called Paris 2018, where the elderly were affected badly. We're going to be in a situation where we're going to really need a contingency plan, which is relational, which does involve the community.
Yes, and I think the extra, I think that is very important. I think the thing that the COVID vaccination programme has shown us, though, is that there is an underlying distrust of the state and statutory services in some communities that is very, very understandable. And I guess it's how do we use that kind of building relationships approach to change that, and social connections is part of it. The other thing we funded actually through the Inequalities Fund, which is just starting, which was the idea of a Haringey GP, is something called talking, which I have to be careful how I pronounce that. But that is around increasing social connections just through walking. So talking and walking, hence its name. And it's been really popular because actually it's not saying you need to wait until you've got a certain medical condition, before we kind of take you seriously as a person. So yes, that started in Haringey, and now we're doing it in Enfield as well. And that's the kind of thing where actually just getting a group of like-minded people together, or not even like-minded, just a group of people together to talk and get some exercise. I'm hoping we'll be able to demonstrate that has an impact on health outcomes, so that we can continue this kind of thing.
One of the
future.
problems, though, that that you have to face, and that's been faced for decades, is about integrated care and joined up working.
Yeah.
And people have tried it. I remember as BBC producer doing a programme on links between local authority and health authority, and helping people to stay in their own homes by having a network group at ground level working with those people. You have to work in partnership to do this with the local authority and with community groups. How easy is that when you've got managers who are trying to protect their positions?
So I would say that it's not easy. But I think what's quite interesting is that you can make the link back here to relationships in kind of every form. So Dudu Sherarami, who is the Director of Public Health at Enfield, I work very closely with. They go for walks together as well, which is a very public health thing to do. But also relationships are important everywhere, aren't they? Because me having a good relationship with Dudu means that we can work together and we can resolve funding differences, and talk through the challenges that we both face, and find some kind of solution together to that. So the thing that we've done with Enfield Council, which will be interesting to see the results for, is that we co-funded community participatory research focused around Edmonton again, but looking at childhood obesity in particular. And this was a really kind of joint initiative, because public health were pointing out that childhood obesity is clearly a massive issue across Enfield, and there's massive differentials by ethnicity and by deprivation there. But what we're trying to do with community participatory research, which again links back into Hilary Cottam's work around the importance of building those local relationships and co-production, is to do really kind of in-depth qualitative research with communities around what is affecting their decision making, because it's not really just about health, it's about what else is going on in somebody's life. And I think it's something like, I'm going to get the number wrong, but I think it's 70% of if you live in a low income household, you'd need to spend 70% of your income to eat a healthy diet. So it's not really just about telling parents and children to eat less sugar. It's about what else is going on in someone's life that's affecting their ability to eat a healthy diet. So that's a piece of work we're doing with EVA, the Enfield group. So it'll be really interesting to see the results of that in terms of what the community thinks will make a difference.
Yeah, I mean, I think working with EVA is great, because they're a great network in their own right, and I think working with networks is really important. But to do what you want to do, it's sort of a culture change, isn't it, for local authorities and for health authorities? And one thing that stands in their way is that particularly local authorities, I think, are worried that if we adopt these new models, it will turn into a mutual aid model where people are helping each other, and therefore they will be spending less on staff, and they don't want to do that. So they find it really difficult to adopt a model that could be more cost effective in terms of staffing, and they're always asking for more money rather than asking for money and saying, well, how do we spend it the best way?
Yes, although to some extent, I feel it's part of my job, or all of our jobs, to demonstrate what we think is the best way of spending money. But to do that in a way in which we're informed by what the local community thinks is a good way of doing that. And I think we're developing a BCSE strategy across NCL at the moment, working with our communities. And one of the things I'm really keen to do is just to be really clear as part of that strategy is, how will we know when something has changed? So I think it's really important to put our ambitions in a strategy. But I also think we'll lose something if we don't then say as a result of that, well how will things look different in the ICS as a result of this strategy? And I think if we can demonstrate that actually, I don't know, as an example, we can demonstrate at the end of the year that this decision was taken, even though this issue wasn't on our radar, the issue was completely raised by our local communities, the solution was co-produced. They thought this would be the best use of this resource to solve that problem. And therefore we've implemented this, hand in hand with them. That's where it feels like we need to get to. We need to be making sure that one of our success criteria as an organisation is demonstrating certain things. And I guess it's it's thinking through how you convert all the fantastic ideas around kind of what's in Hilary Cottam into how we govern ourselves and how we have checks on ourselves as an organisation, both as a kind of ICS, but also between us and local authorities, because there's definitely a lot of willing there to work together. That, from my perspective anyway, from my work.
I mean, it's also not about strategy alone, is it? It's about logistics as well.
Yeah.
I remember Clausewitz, who wrote a famous book in the 19th century on war. He said, strategy is for amateurs and logistics is for experts. And we don't spend enough time in advance thinking through the logistics. We have a strategy, the crisis comes, and then logistics are developed in a panic. We need to be more advanced than that, don't we?
Yes, definitely. But my other favourite quote around that, it's not him, but somebody else, is culture eats strategy for breakfast. So unless you have the right culture, and the other document I like, which is related to Hilary Cottam, is Kindness in Public Policy by Julia Unwin, which is all around, how do we, not just in terms of how we kind of commission services, but ourselves as an organisation, how do we demonstrate those values through kind of both our working life and how we treat each other at work, and how we work with our communities, and how do you build in emotional intelligence as much as anything else. And Julia talks a lot about the comfort of transactional ways of working, and it's true. Once you've got some hard data in about how the local hospital is performing, it feels much more concrete than trying to work out if someone in a care home has been physically touched that week. But actually, that's very important as well in terms of somebody's outcome. So, I think it's making sure that the culture enables that strategy, and that we're all aware that how we act to everybody, whether it's part of how we spend our money, or to the person sitting next to us, or across a computer screen from us these days, is just as important, really, because I think it's very important to live your values when you come to work. So it's as much about.
I mean, I've been talking to the people in the CCG. You're really lucky. You have a great lot of people who do live their values, and they bring it into their job, and that's important. If you're going to have this culture change, though, what's the best way to do it? Is it to do it bottom up with pilots and hoping that those pilots will then let people know this is a different way of working? Or do you have to have a grand design straight away? Or do they have to work together? And how can you do that? That's a simple question, but it's difficult to sort of answer.
It's very difficult. And I think with the Inequalities Fund, we were really keen for local communities to come forward and say, this is what's going to make a difference. But part of the issue with that is that we now have quite a lot of, so we have over 50 schemes now. And I wouldn't ever want to take anything away from them being quite small and bottom up. But equally, other people have said, well, you'd have been better off spending that money on 3 or 4 things, 3 or 4 big ticket items that could make more of a difference. So trying to get a balance between those two things is really difficult, and that's part of the reason we've asked Middlesex University to come in and evaluate them, because it feels like both to demonstrate their impact and to try and make sure that funding doesn't disappear in future years, demonstrating that they're actually doing something and they're making a difference is so important. But it's much harder to measure the softer stuff than it is to measure the harder stuff.
Yeah.
But I think it's equally is important. And actually, when I went to the JOSC, the Joint Health and the Overuse Scrutiny Committee, the councillors were all saying what they'd like to hear back, figures and more people's stories. They were saying what they'd like to see in a year's time is interviews with people. And that's something they did in Brent. They went out and they interviewed both kind of residents and people that were using services, but also the staff that were delivering those services. So you kind of get a rounded view. So that's the way around we are really keen to do it, is to look at that kind of relational impact. But I do think you need a bit of both, because that's not going to please everybody.
Okay, well, we've sort of almost come to the end of the 30 minutes. We've probably gone over it, which is great. I mean, you know, looking into the future, it really sort of encourages me that you and other managers like you are thinking in innovative ways, and not like some of the older managers who were stuck in their silos and didn't want to get out. I mean, are you hopeful for the future that the culture will change? And at a time of immense crisis this century, we will be able to deal or create or develop models that will work in a way that the old models that did work fine for a time, but now we're finding it wanting.
Yes, I am, because there's a lot of it does feel like there's an alliance of people across the system that want it to change. I still think there's quite a lot we have to do to get there. I feel there's quite a lot I have to do to get there. I think we just need to be mindful that we need to work, I think, like you were saying, really closely with our local authority colleagues. So much of health inequalities is rooted in, how people, what work they do, how they grow up, employment, housing, education. We really need to have a kind of combined effort on those things and a focus on prevention and the social determinants, and to be looking at how we close how we look at that social gradient. So one of the things we're interested in is equity ratios, which is a bit of a dry topic, so I won't go into it in detail, but it's looking at how you start to make our services or our offer more equitable. And I think if we can start to shift the dial on looking at it from that perspective, not just on the kind of outputs from a health perspective, which is obviously very, very medicalized. I think if as a system we can shift that dial and look at it in a slightly different way, then we'll be making progress.
Okay, well, one final question, and that is, if anyone wanted to find out more about what you were doing, what you are doing, and what you plan to do, how is it best for them to make contact with you?
To email me, so I can have my email address, which I think you have. I'm very, very keen to hear from people, and I work as part of a job share as well, in terms of everybody having a balanced life. So I love working as part of a job share. So Sarah D'Souza is my job share partner, so I'll give you her email address as well.
Okay, well, thanks very much. I mean, I think that the innovations you're doing already are really, really great. And I think working with local authorities, and especially working with civil society groups that you want to do, is a real plus, because the way we deliver services in the future has got to be a whole society endeavour. It can't be just statutory or business or the commons. It's got to be all of us, and I think you know that, and you're working in that way. So thank you for doing it. I think it's really interesting, and I think all of us will want to sort of help you, work with you, and watch what you're doing, because it's a critical time, but it's an exciting journey everyone's on to make the changes that are necessary. So thank you, Ruth, for joining us.
Yes, thank you very much.
And we'll end this interview now.